Feeding difficulties in children. I know this was a webinar that we were originally scheduled to have last Saturday, but nevertheless, we are here today. We wanted to make sure that we do provide this content to you because it's such an important topic, and I want to thank Laura for being here. Again, it's Saturday night for us, so we're so happy to be here and provide this useful and essential content to increase awareness really among y'all. So Laura Phipps is actually a board certified behavioral analyst, and she's also a doctoral candidate at the University of Nebraska Medical Center. Laura is currently completing her third year as a case manager and a research assistant in the pediatric feeding disorders department at the Mundramy Institute. Before she started at the Mundramy Institute, Laura worked for the public schools, specializing in behavior consultation and assessment for special education services. She earned her Bachelor's of Science degree in psychology from the James Madison University and her Education Specialist degree from Baylor University. Laura, we want to thank you for being here. We are really looking forward to listening to your area of expertise and seeing how we can use that information to help kiddos in Sri Lanka. So thank you for your time. I want to say most of y'all have attended our previous sessions, but as for me, I am a postdoctoral fellow in the Department of Educational Psychology at the University of Utah. My background is in school psychology, and I did my pre-doctoral internship at MMI, where Laura is currently, and that's how we know each other. So today we are going to talk about feeding difficulties in children, and there's some important content that we will cover. Actually, Laura will cover. We'll kind of go, overall talk about what are feeding problems and what they look like, and the different kinds of feeding problems that we typically see in children. And we'll kind of talk about significant differences between what we call picky eating and also food selectivity, because sometimes it may sound similar, but actually they are different. And just like talking about those important and highlighting those important differences. We'll also talk about some of the warning signs. How do you know if your child has a feeding problem? And being able to identify that timely so that we can intervene. And, if it's a medical concern, then, we are timely attending to those. And also we will talk about, for your information, just for your knowledge and your education, just talk about concerns about your child's feeding habits, and also hopefully, if we have some time, be able to address some of those individual questions that you all have. So with that, Laura, I am going to hand it over to you.
All right, perfect. Thank you so much for that introduction. And thank you so much for having me here today. I actually am really excited about this. So I'm going to go ahead and pull up my presentation very quickly. All right, and can you see that well?
Yes, we can see your official screen.
Perfect. Okay, so I'm just going to go ahead and get started then. So my name's Laura Phipps, and I'm a board certified behavior analyst and doctoral candidate. I'm working in the pediatric feeding disorders department at the University of Nebraska Medical Center. And today I'm going to be talking about one of my favorite topics, which is food. Well, a little bit more specifically, I'm going to be going over some general information on childhood feeding behavior and feeding difficulties. But before we get started, I do want to note that I will not be able to answer specific questions regarding concerns about specific children, and that the information that I present today is more for foundational knowledge and to kind of set a guide for you. If you have very specific questions specific to a child, first step is usually to go to that child's pediatrician. So before I kind of get going, I would like to have an idea of what type of interest you guys have today and maybe the main reason why you decided to attend this presentation. So we don't have a poll function for this presentation, but I believe the chat function is working. So if you feel comfortable just responding in the chat function of maybe the main reason why you are attending this presentation, that can kind of give me some insight into kind of how much detail to share and that kind of stuff. Okay. Is there anything coming up or am I completely technologically not advanced? Okay, there's one.
That was actually me. I just put it on the chat group to let us know any questions that you may have. And I will just let you know whenever a question pops up, Laura, so you don't get distracted.
Perfect. Okay. Okay, so basically, I guess there could be a variety of reasons of why you attended today. Maybe specifically you have a child that you're seeing mealtime difficulties occur. Maybe you just want to make sure that a child is kind of meeting the expectations that you have for feeding, or it could be that you've never heard of a feeding disorder, which is actually very common. It's not generally kind of well-known knowledge that kids can have trouble with feeding. So just wanting to learn more about that is totally okay too. Okay. So for today's agenda, I'm going to go over these three things kind of in this order. The first will be typical feeding behaviors, and then what we would consider to be red flags or behaviors that may warrant looking more into what could be going on. And then I'll provide some practical mealtime recommendations, as well as how to go about seeking professional help. So the first question, what is typical feeding, can be answered in a few different ways because feeding involves so many different behaviors. For this presentation specifically, I'm not going to focus so much on the age at which a child usually demonstrates a feeding skill or focus too much on feeding milestones, because I'd like you to focus more on what types of typical feeding behaviors are, and that will help you to identify when a child might indicate difficulty with feeding. So the first mealtime experience for a child begins with the bottle and or breastfeeding, and a newborn child usually initially uses an automatic suck, swallow, breathe pattern. And as he or she ages, that suck, swallow, breathe pattern becomes voluntary and is no longer automatic. So at the beginning of their life, they're not able to control that reflex. And then as they get older, they can start to control the movements within their mouth. We do see that sometimes preterm or ill NICU infants sometimes have difficulties or show difficulties with this suck, swallow, and breathing pattern. And that could be maybe the first sign of a feeding difficulty. One thing that we may see is that the child is taking multiple sucks without stopping to breathe. See a question's coming up.
I usually drop little
Thank
comments.
you. Perfect. Okay. And then in the first 2 years of life, children do really rely heavily on liquids. They rely heavily on breast milk and formula, and then usually transition to milk to meet their nutritional needs while they learn to consume solid foods efficiently. However, once a child reaches about 18 months or older, the child's caloric needs should be met primarily through solid foods. So this is one where we do kind of look at the age. So if a child is older than 18 months and is drinking a lot of milk or formula, and still getting most of their calories from that instead of solid foods, this can be a sign of a feeding difficulty, and we call this liquids dependence. And then afterwards, the first type of solid texture that children begin consuming is smooth puree foods that are typically a single flavor. These are generally introduced once a child learns to sit with support. So they're able to sit up in a high chair with the back against them. And it's also when their suck, swallow, breathe pattern becomes voluntary. So they're in a place to start using their mouth and controlling what's in their mouth. During this time, children will learn to move foods from the front to the back of their mouth with their tongue, which is a whole new experience for them and kind of the first time that they start to figure out how to do that. Yeah, so a suck, swallow, breathe pattern is basically when the child will suck the liquid in, swallow it, and then take a breath after. And they usually will do like maybe even just one suck, one swallow, then take a breath, then do it again. With children that don't have that suck, swallow, breathe pattern working efficiently, you might see that they suck multiple times and they don't swallow right away after their first suck, or they do, but then they don't come up to take their breath before they take their next drink. So this is kind of where they first learn to just take nutrients in. But then after some time, it becomes something that they can control instead of just a reflex. So the exploration continues as the child becomes comfortable with the smooth puree solids. And with that, the child starts to consume foods at what we would consider to be a higher texture. So this could be something like a mashed puree, like baked potatoes. And then we also see the interest in more complex flavors develop around this time as well. So this is like a pureed green bean casserole on here. So having a little bit more flavor than just the single puree of banana or something like that. And they'll kind of start to explore those different higher textures and multiple flavors. This is also where children start to show what we call a munching pattern. And this is where they use their tongue to kind of mash foods in their mouth, and they move their jaw up and down without a diagonal movement. So when we chew, we chew in a way that's called a rotary chew. So our mouths go kind of around. When kids first start learning how to use food in their mouth, they'll mash their jaw up and down like this. And you might see them kind of using their tongue to squish their food. So this is where you start to kind of see that kind of occur with these higher texture foods. And then children start to demonstrate an interest in small bites of soft finger foods like small pieces of cooked carrots or banana. And then when the child's teeth come in, their chewing pattern, as well as the types of regular table texture food they can eat, become more advanced. So a very high texture food would be chicken. And that's something that's going to take a while for the child to get there because they need the teeth in order to be able to chew up that bite. So during these multiple phases where children are transitioning to different textures of foods, they may start to show some difficulties with feeding, especially when they're transitioning from the baby food or the mash food to the table texture foods, and they may continue to prefer baby foods or creamy foods. This can be just a difficulty with new textures, and sometimes we just see that kids need a little bit more time and a little bit more exposure. But it can also indicate some oral motor deficits or some very, very strong particular preferences for textures that could indicate difficulty with feeding. And then some behaviors that may emerge when transitioning to these newer textures are packing, which is this picture of this child up, he's holding his mouth and kind of holding food in his cheeks. Packing is when kids hold food in their mouth for extended periods of time, and they can kind of pack food in different places in their mouth as well. Then we could also see expulsion start to occur, which is when children start to frequently spit out their food, or they may use their hand to wipe it off their tongue. And then we also may see some gagging or vomiting. And if any of these occur frequently, they often serve as indicators of a feeding difficulty. And then some children are kind of first introduced to table textures with meltables. So these are things such as like puffs. So I have kind of pictures here of Cheeto Puffs and baby cereal puffs. And these can be easy for kids to kind of get used to higher texture foods in their mouth without having to chew because they're meltable. However, some children with feeding disorders may get stuck on these meltable foods. And then you may see that they'll try to swallow whole foods or non-meltable foods whole because they're used to just having food be put in their mouth and kind of disintegrate and swallow it. And so if this is the case, it might be just that the child does not know yet how to move food over to the different sides of their mouth. They might not know how to chew, and they might be still stuck kind of in that mashing, munching phase as well. And that can be really difficult with foods that don't kind of melt away as they're in your mouth. So this being kind of stuck at this point with the meltables and the purees when and swallowing table textures whole or expelling them, those could indicate a feeding difficulty where a child will need to be directly taught how to engage in those skills so that they can go up in the ladder of textures for foods. So as children begin to explore new textures, they also begin to explore just new foods in general. And they will start to consume an increasing variety of foods. We tend to say that typical feeding for young children is eating more than 20 different foods and a little bit from each food group. So I'm gonna just show you a kind of a diagram of some examples of foods and what food group they go into. So these are the 5 food groups. We have fruits, vegetables, starches, proteins, and dairy. And so things like bananas, apples, I just learned avocados are a fruit. They go in the fruit group. We have carrots, green beans, broccoli, those kinds of things in the vegetables. You know, potatoes and bread in our starches. Proteins can be meat-based, but can also be other things like eggs or beans. And then we also have our dairy, which is milk, yogurt, or cheese. And we tend to kind of group that in our treatment into the protein section because those dairy foods do have a lot of protein in them. So one of my poll questions was just to see if your child has any favorite foods from like a specific food group.
If you are also working, yeah, thank you for that response, Ramatu. And if you are, if you don't have your own children, but if you are working with children on, you know, increasing food preferences or food selectivity, feel free to drop some of their preferences as well. Dairy and protein.
Yeah, and I do see some kids have preferences for dairy and protein. I especially see preferences for starches. Yes, and fruits and veggies I think are the most challenging foods for kiddos that are very specific with what foods that they like. And then if junk food was a food group on here, they would all probably like junk food. So I do want to add that many children actually do experience minor feeding difficulties during their toddler years. And this is usually in the form of mild food selectivity, which is what we generally consider picky eating, or just refusing to eat some of those foods that aren't as appetizing. This is common for kids that don't want to eat their veggies. And it's not considered disordered because it begins to go away on its own. And usually these children are eating at least 20 foods and eating foods from other food groups as well. However, there is a point where these behaviors go beyond just picky eating, and then they become food selectivity. And food selectivity is the most common feeding difficulty for children with autism spectrum disorder. It means that the child is not eating enough variety to get all the nutrients that he or she needs, even if weight is not a concern. So for these children, selective eating is not a phase, and it's often a part of them just not liking change, which kind of reaches out to other parts of their life as well. So we do usually say that eating less than 20 different foods or excluding whole food groups can be a red flag if it doesn't go away with time. And if the child has extreme reactions to the presentation of those non-preferred foods. So children with feeding difficulties will likely have more extreme reactions to new foods or non-preferred foods, such as throwing the foods. They might have really long tantrums. You may see other problem behavior like aggression or self-harm. And so we would consider these reactions to be different than a typical toddler tantrum. For children with food selectivity, especially children with autism, something as small as changing the environment may be enough to completely disrupt the mealtime and lead to refusal of foods. So you may see a child has a preferred food and they consistently eat that, but they only consistently eat that under a very specific set of conditions. It has to be the same every single time. And if it's not, then it's a no-go. So for example, maybe a different cup or plate that they're not used to, a different location, maybe even a different temperature of the food. I've heard of parents having to put thermometers in the food to make sure that the food is a specific temperature for their child in order for them to eat it. And then even a difference in the brands of food. So foods could be the same. So I have here a picture of chicken nuggets. That's one food that I see a lot of kids go to, but it's often very brand specific. So those are all changes that could disrupt behavior in a child with a feeding disorder and could disrupt their feeding behavior pretty significantly as well. And then lastly, I'm just going to go in briefly about independent feeding. So there are also a few stages that children go through to advance to eating independently. The first skill we see with regards to independence is self-drinking from a bottle. So this is where the child learns to support the bottle by his or herself. And then we start to see interest in self-feeding when higher texture purees and those finger foods are introduced. So around that time where you see the mashed foods and the soft baby foods, or even the meltables, is where you start to see kids become a little bit more interested in self-feeding, because they're able to kind of move their body a little bit more. So at this time, children may start to kind of play with the food. They may throw the food, but in a playful way. And they may even want to play with like the utensils. So you might be feeding them while they play with the utensils and kind of figure out what those are. And then they slowly begin to show that they can control the utensils. They can control their fingers to deposit the bite successfully into their mouth. And then the last skill that we tend to see is self-drinking, or readiness for self-drinking from an open cup, and self-feeding with utensils independently and successfully. And this is usually by year 1 or 2. So that's also where we kind of look at age. But this is because this is when the child typically has a well-established control over their body. And around the same time that we see the introduction of self-feeding and utensils, we also see that portion sizes and the size of the bites start to increase. And that allows children to be able to consume more solid foods and reduce their reliance on liquids for calories and nutrition. So that's also why at around like the 18 months or older, if a child is still very dependent on liquids, that usually suggests that they're not taking in enough foods to meet their needs, and they may not be around this developmental stage yet. Sometimes children may be successful with foods and chewing foods, but they may take really tiny bites or take very long breaks in between their bites. So they may need a caregiver to supervise them and often prompt them and remind them to finish their meal. So a big sign of a feeding difficulty is when meals are excessively long or inefficient. So I did want to ask and see, how long do you think a typical meal should last? "30 minutes is right." That's exactly right. So yep, 30 minutes. If a meal is taking an hour, it's probably would be okay at a restaurant with family because you're talking and waiting for food to get to your table. But for the most part, once the meal is presented to a child or the portions presented to the child, it should take about 30 minutes for them to consume that and be done.
Laura, I actually had a follow-up question. You know, when it comes to meal times, what kind of an environment should be provided? Because I know sometimes, you know, for some kids, if you put screen time in front of them while they're eating, it's probably like the best way to get them to eat whatever is in front of them. But is that recommended? And if not, what kind of an environment do you suggest?
That's perfect question, because that is actually coming up in some of my slides on practical mealtime recommendations. So hopefully I'll address that. And if not, then just remind me and I'll try to elaborate some more. So this is a big indicator, or kind of what we would consider a red flag for feeding difficulty, which is in extreme situations, some children will not eat foods even when they're hungry. So a child who is simply a picky eater is likely to give in at some point and eat the vegetable or eat the strawberry because they're hungry and there aren't other options. However, a child with a feeding difficulty is likely to not eat those foods, and they can even go days without consuming anything. So often one of the very first things that I tell parents before their child comes in for treatment is, don't restrict foods or try to wait out the child with the hopes of increasing the appetite. Because if they do have a feeding disorder, it's safest to just continue to provide the opportunities for them to get the calories that they need. And then once they're in intervention, they're receiving supervision from multiple medical professionals, that's when kind of restrictions and things can be added into the mix. And then there are some children who will not consume solids or liquids orally at all, which is called total food and liquid refusal. And this is definitely a red flag. This is usually requires that if left untreated, the child will start to or need to receive a G-tube, which is a gastronomy tube, or they might need an NG tube, which is the tube that goes through the nose. And this is so that they can meet the calories and nutrients that they need since they're refusing to eat orally. So I do have just kind of some diagrams of what that kind of looks like for these kids. And I will say that G-tubes and NG tubes are not made to be kind of a sustainable treatment for kids with refusal. So our hopes are always to get them into intervention and get them eating orally at some point. And then in addition to looking at typical feeding behavior, we also look at if the child is meeting growth needs. So these are just examples of growth charts where we plot the child's height and weight according to their age to see if they're following what we call the growth curve. So this is something that can help us, especially with kids with general overall refusal or kids that eat a limited quantity. We'll look at this. However, for kids with food selectivity, we might not see an indicator in these growth charts because they are consuming foods. And it may be that when the registered dietitian looks at their nutritional analysis, that's where we're able to see how their selectivity is impacting them. We may see some nutritional deficiencies because they're not getting those nutrients from the foods that they're consuming. Okay, so that's kind of a general overview of some of the typical feeding behaviors and kind of some of the things to look out for. So now that you know typical feeding behaviors and red flags, I wanted to provide you with a few suggestions that you can use after this presentation to improve mealtime structure and to help potentially reduce difficult mealtimes. A disclaimer, however, is that these are considered antecedent interventions and are not considered intensive feeding interventions. So I will be providing information on intensive feeding treatment towards the end of the presentation, but these interventions are not considered intensive treatment recommendations. So I guess if some of you are working with families and this isn't specifically for your children, one of the questions I had was, do you have a mealtime schedule where you eat at the same time every day? And this could be if you want to kind of answer with regards to the children that you're working with, like, do they have regular mealtime schedules set up in their home environment?
So these are like individual times that are set up to have breakfast, lunch, and dinner.
Yes, yes. Perfect. Then your families are off to a good start then, because that is the first recommendation that I give to families is to set a predictable mealtime schedule and routine that works for the family and works for your kids. Adding in predictable meal times and structure can help to alleviate problems with transitioning. So if you have a child that has issues transitioning to the table or getting started for a meal or going from, preferred activity to the mealtime, having a set schedule can help to alleviate that a little bit, and can also just help with feeding behavior in general, because we know that children respond well to structure and being able to predict their environment. And I think I just saw a chat.
Yes, we had a participant say that they do have a specific timing, especially in the daycare, where everyone just sits together and eats.
And I just clicked something wrong, so I might have to reopen this.
We can see the presenter screen, really.
Okay.
Yeah, I mean, the audience screen.
Okay. Okay. So another recommendation, and I love this recommendation, is to make mealtimes time-based instead of behavior-based. And what that means is that instead of ending the meal based on how long the child takes to eat the food or when they want to finish the meal, which could be within 2 seconds of getting to the table, or could be an hour after you set up the food, you would set up the timer or how long the meal should take, and then end the meal once the time is up. So for that general rule of thumb, for 30 minutes for a meal, you might set a timer for 30 minutes. This is our lunch time. You have to sit at the table for this time until you finish your meal. If you don't finish your meal, you still have to sit here. And then if they don't finish at the 30 minutes, you go ahead and remove the food. And anyway, so that they learn every time I come to sit down for my lunch, it's going to be 30 minutes and I can eat or not eat. And for those kids that have very specific preferences, this could be also where parents present those preferred foods before they go into intervention and you start targeting kind of non-preferred foods, because you do want to make sure your kids are getting some calories. But we do see that that can kind of help to reduce problem behavior that may be reinforced by escape from the meal. And then another suggestion is to try to have the child eat in the same location or place every day for their meals, so like the kitchen table. And this is another way to keep meal times predictable, so that they learn that when I sit in this chair at this table, this is when I eat, and this is, this is business time. I got to eat my food now. And we could call that the stimulus control. So just having a specific context so the child knows this is eating time. And then some kids, though, they may eat in the living room, they might eat in the bedroom, they might eat somewhere that fits for the family. And if that's the case, just keeping that kind of consistent, but trying to limit distractions. So things like TV, iPad, toys, if you can limit those and then provide access to those after the child has finished their meal successfully, that can be a lot more helpful in getting them to focus on food, eating, business time, then they can get their toys and things afterwards.
So Laura, I have actually a follow-up question. So does that mean, like, for example, if a child is refusing to eat rice and chicken, is it recommended for parents to say, okay, if you finish this, then you can have some ice cream? What do you think about that?
I think if that is an expectation the parent wants to set, the best thing to do is to set that rule before the child starts to engage in refusal behavior. So let's say you're in the moment, you present the child with their food, they eat the foods they like and they have rice and chicken left, and they start to throw the food on the floor. If in that moment the parent then offers, if you eat your ice cream, if you can have ice cream if you eat that, then what's actually happening is throwing the food is reinforced by this opportunity to get ice cream that wasn't there before. So if the parent is going to present something that they know the kid won't like, it's better at the start of the meal to say, if you eat your chicken and your rice, then when you're done, you can have some ice cream. And I think then that's okay, just as long as it's not something that's been kind of manipulated by the child for the parent to kind of bring into the mix.
Yeah, so that means if you know your child is going to refuse this food even before you present, just like indicating, oh, I know my child does not like this food, but I'm going to reinforce by saying, if you eat this, then you can have this, and then present the food.
Yep, and then just being really strict with follow through. So if the child doesn't eat those non-preferred foods, making sure they don't get ice cream for other things during the day, just keeping ice cream for their next opportunity.
And also, I think it's important to present the ice cream immediately when they finish their food. Okay.
Yes, yep. Immediately is the right way to go. And I would say also something that we see with kids with feeding difficulties is they're really sensitive to just the presentation of like utensils and plates and things related to meals. So if they finish the bites that they're supposed to have, and then you're switching over to that kind of reward time, removing the plates associated with the non-preferred foods immediately is also really important. So you're providing immediate escape and then providing the reward exactly at the same time.
Laura, you're on mute.
Yep, I just noticed. Thank you. So also appropriate seating for the child can help with their posture, which can also help with facilitating efficient and proper eating, but it can also prevent any running away from the table that could occur. So if kids are small and this is an appropriate chair for them to sit in, then we wouldn't really consider that a restraint. We would consider that something to help facilitate the meal. It's appropriate for their size, their age, but it kind of has that added benefit of not allowing them to escape from the table when you're giving them food. So those are some things to recommend if you see that a child is pretty young and small and the parent is just having them sit on the floor or sit on a big chair. Recommending appropriate seating can be helpful. And then a really important suggestion is to be positive with the child by providing praise for taking their bites and their drinks and really acknowledging and paying attention to the appropriate behaviors that we want to reinforce. So an example would be if the child eats their meal within, their reasonable time frame, then they get to go play afterwards, and the caregiver provides a ton of praise about how they did a really good job eating their meal, finishing on time. And then with regards to trying new food or trying something that they won't normally eat, this is also something that is great to just provide like lavish praise for, but also to follow the child's lead in this situation. So if a child consumes, like, let's say a baked bean, they've never had that before, and providing them praise is exactly what you want to do. But then afterwards, caregivers may be so excited that then they give them another baked bean and they say, oh my gosh, you did such a good job, here's another one. And sometimes that can be slightly punishing for the child if that's the first time they've gone to try it. So I do recommend just kind of following the child's lead. So let's say they do reach for another baked bean, then that's fabulous. But if they don't, then just being super happy about that one little step and then continuing to take those steps afterwards. And then this one is the tricky one, but try not to provide additional attention to refusal behaviors. Like saying, why are you not eating? Or you always like this, why don't you like this anymore? Kids are also very sensitive to facial expressions. So they can tell when a caregiver or a feeder is reacting to their negative behaviors. And this can unfortunately cause those behaviors to occur again in the future. So even just a sigh or rolling eyes, things like that, kids are smart, so they pick up on that stuff.
Is it helpful to like prompt? So like suppose a mealtime is, given that a mealtime is supposed to last approximately 30 minutes, and you see that, you know, a child is just staring at the food or eating slowly, and you know the 30-minute time is approaching, is it helpful to like prompt them, remind them, give them cues like eat your food, or you know we have this much time left, or how would you kind of go around that?
That's a really good question, because when we're in treatment, we try not to provide prompts just because we don't want the child to become dependent on the prompts from the parent to consume their meals. We want them to be independently eating. But in the context of not being in treatment, I think it's okay for the parent to provide some prompting. My suggestion would be, again, to keep the prompts time-based instead of behavior-based. So instead of waiting for the child, seeing that they're not eating, oh my gosh, it's been 2 minutes, then prompting them, maybe kind of the parent setting their own timer or something and thinking, okay, it's been about 5 minutes, I'm gonna go check on my kid and prompt them to eat. If they're eating, then I'll give them praise, and just kind of trying to keep it as time-based, systematic as possible, so that you're not, or the parent is not unintentionally reinforcing that behavior or creating prompt dependency. And then lastly, prevent grazing between meals if you can, so that your child has an appetite for mealtime. So this can be a little bit confusing with the suggestion of not restricting foods for kids with feeding disorders. What this means is it's not restricting food in the effort to make the child hungry and kind of give in. It's just restricting volume across the day, so that when they do sit down for their scheduled meal times, they may be more hungry, or they may just be able to take in more in their stomach. And this also creates things to be more predictable. So if kids are used to just grazing all day, the likelihood of them eating at mealtime is pretty low.
So to clarify, grazing is essentially like eating constantly throughout the day, just like snacking on foods.
Yes, exactly. Just kind of eating snacks all throughout the day. And I've had some caregivers, you know, they had like Cheez-Its and things available for the child, or goldfish available for the child all through the day. And then that child didn't eat dinner. And so then we started to keep those Cheez-Its and goldfish only available during dinner time. So they weren't kind of grazing on those up to that meal. And then they were consuming foods at their designated meal times with the family.
So outside like the main meal times, how often is snacking recommended?
So snacking is recommended about 2 times per day. So in between breakfast and lunch, and then in between lunch and dinner. And then sometimes I do see kids kind of eat a snack after dinner as well, if they stay up late and just need those extra calories. And then just a reminder for caregivers and for those working with caregivers, that when you're making these adjustments, remember that they take time. And it's good to kind of try to change one thing at a time as you practice these suggestions. So instead of taking this kind of all these notes and then going in and just changing everything, that can make it hard to know exactly what is working for the child, and can be a lot for them too, for that much change. So kind of picking the most significant thing, and then working on that, and then continuing on. So the most significant would probably be the mealtime schedule and reducing grazing, I would say. and then continuing on with those other adjustments. And then if you do make a change, try to stick to it for a couple of days before making further adjustments. So for example, let's say you introduce breakfast, it's always at 9 a.m., the child's not eating that much. You may try breakfast at 9 a.m. for a couple more days that week before making adjustments, just because it does take some time for kids to catch on to these changes. And then remember that it's okay to make small changes, to adjust to a new routine, and to try things out. Not everything is going to work, but these are just kind of suggestions that could help. And change doesn't happen overnight. So it is a lengthy process. And then if you're still seeing some red flags and no improvements with this added structure, the first step to take is addressing the issue with your pediatrician or with the child's primary care doctor or primary pediatrician to rule out any medical concerns. Sometimes kids can have allergies that we're not sure of, or they're experiencing some pain and discomfort when they eat, which is kind of associating eating with that pain. And so the pediatrician will be able to ask the right questions and figure out what further testing needs to be done before just assuming the child has a behavioral feeding disorder. It could be, something else. So here I just have a slide of kind of the origins of feeding disorders to show that feeding difficulties often have many factors that play into them and that contribute to their development and the maintenance. So treatment is always or should always be individualized to the child, because you may see a child has more medical conditions associated with the feeding disorder, or maybe it really is heavily behavioral, but there are still some other components like oral motor difficulties that are occurring as well. So being able to understand that it's not just one thing, but it can be multiple components that contribute, kind of helps with figuring out treatment. And so if a child is referred for treatment, the approach for a pediatric feeding disorder is multifaceted, and the treatment should be interdisciplinary. So there really shouldn't be one person that is working with that child specifically on feeding. There should be multiple people that are collaborating together to figure out the different components of how to make sure that that child's successful. So different healthcare professionals with different credentials will be working together to develop individualized treatment for the child. And here I just have kind of a list of some different medical professionals who specialize in feeding and have training in different areas that tend to work collaboratively with kids with feeding disorders. So one of the main ones is the gastroenterologists, and these doctors look at the digestive system. They're able to identify patterns in constipation, irregular bowel movements. Maybe if the child is vomiting a lot, it could be something else associated with the food rather than just a texture sensitivity or something like that. So they can be really helpful in figuring out ways to make sure that treatment is safe. And then we also have our registered dietitians and nutritionists that monitor the child's growth needs. They may set recommended meal schedules and recommended volumes. They can be very helpful at being able to transition kids from G-tube dependence to then consuming solids, or for some of those kids that are still relying on formula and never transitioned over to milk, they can be really helpful at getting that transition over appropriately, making sure kids are meeting their nutrition needs. So they're definitely an integral part. And then we also have speech language pathologists who are often looking at swallowing problems, as well as just different oral motor deficits. And for those kids with autism spectrum disorder, we also collaborate with speech language pathologists on teaching communication as well. And then occupational therapists kind of look at how to help a kid be successful in everyday life and the adaptive skills. So they can be really helpful in trying to figure out how to make feeding easier for a child, or maybe like if a child has low muscle tone or they need to use a certain spoon to be able to scoop properly, an occupational therapist can provide those resources to help accommodate for the child. And then physical therapists as well. They're more kind of like gross motor and big movement, but they also can be really helpful with making sure that feeding is functional for the child and their family. And then lastly, we got behavior analysts, which is me, and then licensed psychologists. And our primary role is just to apply the study of the science of behavior and work to improve the child's function through behavior change and modification. So we work with all these other members of the healthcare team to make sure that the appropriate behaviors are reinforced, the environment is set so that the child can be successful, so that parent training is effective, and just making sure that everything can cohesively work in a system that is long-term for that child. So we're at the end of the presentation, and we do have, oh shoot, we might not have time for questions.
It was a great presentation, Laura. I think it's just super helpful information, and it's sometimes hard to cover everything in exactly 60 minutes. But we still have all of our presenters on here, so that's good.
Yeah.
I just wanted to see, I know we did address questions as we went, but I just wanted to see if anyone has any questions, maybe any specific questions that we can probably address. But at the same time, I just have a question for the audience. Are there like maybe clinics or therapists that really work on increasing or improving feeding practices in children? And I'm asking this because I left Sri Lanka in like 2015, so things have changed a lot, things have improved a lot. So just curious to know if there are any feeding clinics in Sri Lanka, if anyone has heard of any. In the meantime, I am going to quickly share my screen as well. Okay, thank you, Laura. Okay, so while we wait for questions, I just wanted to give everyone a quick reminder of our session for next Saturday. We are going to touch on toilet training and really, speak about concerns to toilet training. What does toilet training look like? How do you know your child is ready? Where do you start? And some strategies that if we have parents, if we're going to have parents attend the session, what are some strategies that you can do at home? And also if we have teachers or, like Montessori teachers or daycare teachers here, what are some things that y'all can do to kind of help children maintain those skills, or even like teach some of those skills that the parents are doing at home? And with that, of course, these are new skills for children, so they are going to experience difficulties. Sometimes it's very smooth, but we definitely have children who need extra help. So what are what are those difficulties, and what are some strategies that we can apply just to help those kiddos? So a reminder of that session, we do have people registered for that, but let me quickly drop the link for that session. Yeah, so with that, we come to the end of our webinar today.